Autonomic drugs. I know you're probably tired of me saying this, but this is crucial for understanding pharm. Drugs can mimic or antagonize the normal occurrences within our body. Therefore, we first need to always ask ourselves, what is normal? There are two types of synaptic terminals that compose the autonomic nervous system: cholinergic and noradrenergic. Let's start with the cholinergic synaptic terminal. The production of neurotransmitters is just like an assembly line. We get some products, put them together, and then package them out to be sent. To make acetylcholine, choline has to be pumped by the choline transporter into the neuron. Then the enzyme choline acetyltransferase transfers an acetyl group from acetyl-CoA to choline, forming, you guessed it, acetylcholine. Acetylcholine is then packaged into vesicles by the transporter, vesicular acetylcholine transporter. When the neuron's membrane depolarizes, voltage-dependent calcium channels open. The influx of calcium activates the synaptosomal associated protein, or SNAP25, or SNARE, which causes the fusion of vesicles with the membrane and the release of acetylcholine into the synaptic cleft. Once released, acetylcholine will bind either a nicotinic or muscarinic receptor and be degraded by the enzyme acetylcholinesterase, now that's a mouthful, into choline and acetate. So now that we understand how normal works, let's discuss some drugs that can act and interfere with the acetylcholine pathway. Do you remember what drug competes with choline for the choline transporter? Hemicolinium, which is actually an ion made of two halves of choline and inhibits choline uptake. What about the drug that inhibits the packaging of acetylcholine into vesicles? Vesamicol inhibits the vesicular acetylcholine transporter. Now, hemicolinium and vesamicol are experimental drugs used on rats, so no one in their right mind would ever really consider giving these to a patient. Now, do you remember from micro what the botulinum toxin causes? That's right, it causes paralysis. So to tie this into pharm, how does botulinum toxin do this? What's its mechanism of action? Botulinum toxin interferes with cholinergic neurons. It cleaves SNAP25, disrupting the fusion of vesicles and preventing acetylcholine release. If we prevent the release of acetylcholine at the neuromuscular junction, then this would lead to paralysis. Okay, so many of you are probably thinking that it would be crazy to give a patient botulinum toxin, right? Well, as it turns out, botulinum toxin, aka Botox, is famously used for cosmetic purposes like wrinkles, but it can also be used to treat various muscle disorders. Can you think of a serious condition from your GI chapter where Botox can be a form of treatment? Achalasia. In achalasia, the lower esophageal sphincter fails to open up during swallowing, leading to a backup of food within your esophagus. So administering Botox can relax the smooth muscle, allowing for dilation. Now, Botox can also be used to treat hyperhidrosis or excessive sweating. Let me ask you this. Do you remember what receptor is found on sweat glands? It's a muscarinic receptor, specifically M3. That is why administering Botox, which prevents the release of acetylcholine, would be helpful in people who sweat too much. So we spoke about a few drugs that can inhibit different steps in this cholinergic pathway. There are also drugs that can inhibit another part of this pathway, called acetylcholinesterase inhibitors. But don't worry, we will get there in another lecture. Moving on to the noradrenergic synaptic terminal. This might be one of the highest yield pathways in this entire book because it encompasses information from both biochemistry and neurology. So it is super important that you know every step of this pathway. I'm sorry. Whenever we are making catecholamines, we will always start off with the amino acid tyrosine. Once tyrosine is in the neuron, tyrosine hydroxylase converts it into DOPA. DOPA is then converted by DOPA decarboxylase into dopamine. Dopamine is put into vesicles by the vesicular monoamine transporter and can be further modified into either norepinephrine or epinephrine by dopamine beta hydroxylase and PNMT respectively. It is important to note that the release of which catecholamine depends on where synthesis stops along the pathway. For example, most postganglionic sympathetic neurons release norepinephrine, but in areas such as the adrenal medulla, norepinephrine is further converted into epinephrine. And in dopaminergic neurons, such as in the substantia nigra of the brain, the pathway stops at dopamine. When the neuron's membrane depolarizes, voltage-dependent calcium channels open. The influx of calcium causes the fusion of vesicles with the membrane and the release of norepinephrine into the synaptic cleft. Once released, norepinephrine can bind alpha or beta receptors. Now, I want you to take notice of the alpha-2 receptor here on the prejunctional nerve terminal. This receptor plays a role in negative feedback, aka the regulation of norepinephrine release. When norepinephrine binds this receptor, it tells the neuron we already have a lot of norepinephrine in our synaptic cleft, so stop releasing it. Finally, norepinephrine's effect is terminated by the reuptake of it back into the presynaptic terminal via the NE transporter. So now that we understand how normal works, let's discuss some drugs that can act and interfere with the norepinephrine pathway. Here are a list of drugs that act on the norepinephrine pathway. Taking a look at metyrosine, just by looking at the name, what would you say this drug inhibits? Metyrosine is an antihypertensive drug that inhibits tyrosine hydroxylase and prevents the conversion of tyrosine into DOPA. Do you remember carbidopa from our neuro chapter? For what disease do we use this drug, and how does it exert its effect within the adrenergic pathway? Carbidopa is used in the treatment of Parkinson's disease, and it works by inhibiting DOPA decarboxylase in the peripheral system, preventing the conversion of L-DOPA to dopamine. Reserpine blocks VMAT, preventing the storage of dopamine into vesicles. This drug has been used in the treatment of what disorders? It can be used as an antipsychotic and also in the treatment of hypertension or high blood pressure. And how do amphetamines and ephedrine compare to the drugs beryllium and guanethidine? Amphetamines and ephedrine potentiate, while beryllium and guanethidine inhibit the fusion of vesicles and the release of norepinephrine into the cleft. What are the similarities and differences between clonidine and mirtazapine? Clonidine and mirtazapine both work on the autoregulatory alpha-2 receptors found on the prejunctional nerve terminal, but clonidine works as an agonist and mirtazapine as an antagonist. Clonidine decreases the amount of norepinephrine released and therefore can be used in hypertensive emergencies, while mirtazapine, as you may recall from your psych chapter, is an atypical antidepressant and works by increasing the amount of norepinephrine released. Why do we give ACE inhibitors to patients with hypertension? Remember from your renal chapter, ACE inhibitors decrease the amount of angiotensin II produced. Taking a look at our neuron, we see an angiotensin II receptor on the prejunctional nerve that, when stimulated, increases the release of norepinephrine. Therefore, giving an ACE inhibitor will decrease the stimulation of this receptor, and less norepinephrine into circulation will decrease vasoconstriction and blood pressure. Notice here on the left Then again, we see amphetamines listed with cocaine and tricyclic antidepressants. All of these are able to inhibit the norepinephrine transporter, preventing the reuptake of monoamines. Can you name a drug that we give for depression that also inhibits the reuptake of norepinephrine as well as dopamine? That's right, bupropion. We just spoke a lot about drugs that can interfere with our adrenergic pathway. But before we end, I would like to take a few minutes to discuss the high-yield monoamine called tyramine. Interestingly, all monoamines can be oxidized and inactivated by the enzyme called monoamine oxidase, or MAO. Now, MAO comes in two flavors. MAO-A inactivates the monoamines norepinephrine, serotonin, and tyramine, and MAO-B inactivates dopamine. Now, tyramine is found a lot in cheeses and wine. So let's create a little vignette of how you could be tested on this topic. So I'm quite fancy and love foods rich in tyramine, such as good cheese and wine. But unfortunately, I'm also suffering from atypical depression, for which I take phenelzine. Why am I at risk for a hypertensive crisis? As you may recall from your psych chapter, phenelzine is a monoamine oxidase inhibitor. So if I'm eating foods rich in tyramine while also taking an MAO inhibitor, this will cause an excess of monoamines to be floating around. My MAO enzymes are seriously struggling to work, and the few functioning ones will allocate their energy to break down the excess tyramine from the cheese and wine that I'm consuming, while ignoring other monoamines like norepinephrine. The end result is that there will be much higher levels of norepinephrine, and that can severely elevate my blood pressure by excessive sympathetic nervous system stimulation. And this is known as hypertensive crisis.